Hello, everyone. This is Karen O'Hara, Director of Marketing and Communications with WorkCare. Welcome back to the 14th week of our series on preventing and managing COVID-19 in the workplace. You are on mute during the session. Please submit your questions using the Q&A function on Zoom. We will be recording and uploading the recording on our YouTube channel later this week, and we will also be summarizing all the questions and answers in writing and posting that on our website at workcare.com. When you visit our website, you might also want to check out some new training courses that we're offering. They're specifically designed for California employers because the regulations in that state are particularly specific regarding COVID-19 instruction. But there's a lot of interesting and useful information in those courses that are applicable across all jurisdictions. Our speaker today and every week is Dr. Anthony Harris. Dr. Harris is a board-certified occupational medicine physician. He's WorkCare's Chief Innovation Officer and Associate Medical Director for On-Site Clinical Operations. He's got a really interesting topic this week, so I'll turn it over to him so he can jump right in. Thank you, Dr. Harris, and thank you all for joining us.
Excellent. Thank you, Karen, and thanks everyone for joining us once again here for week 14 of our weekly COVID update. So we're going to jump right into it. This week we got a lot packed in, and so we'll try to get through all of it here today for you. As usual, clinical update. We'll talk about the pathology, microbiology updates. From an epidemiologic standpoint, we'll let you know what's the latest trends with COVID, and then we'll talk about prevention and then workforce strategy. Today's topic is an interesting one that we chose. We chose it because you all are familiar with the movement of Black Lives Matter. We're going to talk about Black Lives Matter and why it matters to employers and why it matters for COVID specifically. And the goal of today, as we cover it, is going to be to get you to think outside the box in terms of how you help protect your workforces, and particularly around some of these socioeconomic factors. Okay, so we're going to frame it in a way that you're familiar with from an EHS standpoint, a safety standpoint, but we're going to also hopefully spark some different ways of thought in that regard as it pertains to Black Lives and Brown Lives Matter, Brown being Hispanics. So let's jump into some of the clinical updates here. So the update we want to talk about today is something that you may already be familiar with to an extent. We've gotten a lot of questions about this, and so I wanted to nail this one down in terms of the use of Pulseoximetry, measuring someone's oxygen saturation in their blood as a means to understand their risk of exposure and or have they been exposed to COVID-19. Some have thought, hey, I can measure early on continuously, and if it changes my oxygen saturation level, that may mean I have COVID-19. And so is that true? Well, let's talk about the phenomenon real quick. So the phenomenon it has been described as hypoxia. Hypoxia meaning low blood oxygen concentration, okay? And that just means that your lungs aren't exchanging oxygen into your blood effectively. And what has been shown is that individuals have showed up to the emergency departments, not necessarily because of their hypoxemia, but for other reasons. And when the doctors at the emergency department measure their level of oxygen in the blood, it's tremendously low, okay? And normal in the blood is 95%. Below that, you start to see typically some symptoms for that individual. Maybe they have difficulty breathing or they feel short of breath, but these individuals are showing up with no symptoms from a respiratory standpoint in regards to work of breathing, which is why they're called hypoxia in those quotes there. But in terms of what actually may be happening in regards to the clinical understanding, we won't go into depth around the whole partial pressures of the lungs and concentrations of oxygen and CO2. what we want to fundamentally understand, though, is that the virus, when it affects the lungs, may be causing small little blood vessels to block. So just as you recall, if you were with us for the presentation on COVID toes, and the reason why COVID toes form are little microvascular blockages caused by the virus, the same phenomenon may be happening in the lungs, it's thought. And that blockages in those small vessels may be preventing the lungs from distributing oxygen into the blood, okay? What's not happening very likely is that the clots are not stopping the lungs from getting rid of CO2, CO2 being the byproduct of respiration. And so people aren't feeling an increased work of breathing or are not feeling short of breath because our brain is wired to monitor CO2 rises versus a drop in oxygen. And so in fact, when you have a oxygen saturation device, a oximeter at home, that can be used as an early indication of someone doing poorly in conjunction with your primary care doctor, but is not to be used in terms of trying to diagnose COVID, okay? And again, normal being 95, below normal, below 95, and that may prompt a visit to your doctor or prompt a telemedicine visit. And even the American Lung Association has said, look, this should not be used, meaning pulseoximetry, as an early indication of COVID-19 diagnosis. It's only an adjunct for physicians and clinicians to help in the, not just diagnosis, but in the prognosis or triage, if you would, of individuals as to how they might fare in regards to their experience with COVID infection. Okay, and so that was the clinical update I wanted to give you. We got some meat and potatoes here on the microbiology piece as well, because we want to update you on vaccines, and we want to update you specifically on some early success that's being seen in China. This is a product that is manufactured from one of China's government-owned pharmaceuticals. And this one in particular has showed early results in its distribution to workers in the workforce. And in particular, they've already vaccinated in this particular study that's in the phase 3 clinical trial over 1,000 workers. And what they found is that when these individuals were vaccinated with what's called a killed virus or an inactivated virus, the COVID-19 virus, they were able to reach 100% in one case, in several cases, in terms of the one of the arms of the study, up to 100% of those individuals developed some immunity to COVID-19, meaning their antibodies responded for being able to attack the COVID-19. So let's dive a little deeper into that. And what does that actually mean? Because again, the claim is after 0 to 28 day in their program, they're able to reach this 100%. So let's talk about what it means to create and administer a killed virus. The virus itself, right, if it's active, can replicate in the body. What scientists are able to do is kill that virus, in this case using energetic radiation. So you bombard the virus with radiation that kills the virus because it disrupts the genetic material. We all know that's a consequence of exposure to radiation, right? So we use that to our advantage to inactivate the virus. Once the virus is inactivated, such as like a hepatitis A, influenza, or polio vaccine, then it's quote unquote safe, right? Meaning that it can be injected and it won't multiply. And so in this case, the COVID-19 virus is inactivated. Once it's inactivated, it's administered as a vaccine. And your body then recognizes still those proteins on the surface of the virus, the antigens, right? And those proteins can still elicit a immune response. And that immune response is called seroconversion, okay? And that seroconversion means that your body has recognized something foreign, has formed antibodies, but they're different types of antibodies, okay? And so the next phase of this particular study, based out of Wuhan, China, and this pharmaceutical, is to now see whether or not the types of antibodies produced, which are called neutralizing antibodies, can actually help prevent future infection infection of COVID-19. And so the differences between the type of antibody response, neutralizing is that you have your antibodies attached to the virus as depicted here, and the virus can no longer attach to your cells, can no longer get in and infect cells. So you've basically neutralized or blocked that virus from being able to successfully replicate. This is in juxtaposition to replication of antibodies that can actually kill the cells that are infected, okay? So if you have a cell that becomes infected by a virus, your antibodies can recognize that something's changed in that cell from the infection and attack that cell to cause that cell to die and again, kill the virus as a result, or stop the virus from being able to replicate as a result. So these individuals in this study developed neutralizing antibodies, not the antibodies that can actually cause cell death, but yet and still, that's what's moving forward. It looks promising so far in regards to the seroconversion of individuals in the study. So good news. So let's talk about some of the epidemiology updates. Okay, where are we today as opposed to several weeks ago? So a couple weeks ago, 2 weeks ago specifically, we were at 1.8 million cases. Last week we climbed to 1.9 million cases, and this week we're at 2.1 million cases. So we leaped, right? We leaped more than 200,000 cases, and we'll talk about a little bit of what we see with that leap and potentially what's going on there. Deaths also climbed as well. If we look then at total new confirmed cases on a 7-day rolling average, with the US, this was again a couple weeks ago, where we were last week and where we are this week. So the curve is relatively still flat, right? We're not downtrending tremendously, relatively still flat in terms of that 7-day rolling average. But if we look at deaths, we had a little a blip, if you would, a couple weeks ago, trending down again last week and continue to trend down in terms of 7-day average in the US for deaths of COVID-19. If we look then back at some specifics on confirmed new cases, right? We introduced this chart last week for the first time, looking at the number of tests conducted to uncover one positive case of COVID-19. This is where we were back on May 10th, okay? And so we looked at this on May 10th. We looked at it then on last week, June the 9th, to see where we were, okay? And as we keep moving forward, we can see that as of the 15th, where we are, right? The number of cases, confirmed cases with the test, okay? The number of cases confirmed. We want to look at also then a 7-day rolling average for number of positives, okay? So this is a different chart we want to introduce this week, looking at the percentage of positive cases for the tests conducted. All right, so now we're specifically trying to identify how we're faring specifically to the number of tests conducted and the number of cases we're finding. And we know that the number of tests we're conducting is continuing to grow in the US. All well and good, that's what we want. But what we're seeing here on this map is that we were between 5 and 10% of the tests conducted were resulting in a positive case of COVID-19. That was back on, again, May 11th. If we look at then what happened on a week later than that, on the 18th, we were still in that zone. What we want to be seeing, right, is a decrease in that percentage, because that points towards increased number of tests and decreased number of incidents of COVID-19. And so, in fact, as we move forward week to week, we're still in that orange zone, 5 to 10%, and then we dropped. All right, back on June 1st, we dropped down to that 2 to 5%, which is a good sign, right? We want to make sure that we're detecting the virus, and we want to make sure that the incidence is decreasing, right? Being too high, if you recall from last week, if you're too far shifted to the right and you're in that red zone, that means you may not have enough tests being conducted to accurately articulate the burden of illness. And so again, good that we dropped down to the next level in that 2 to 5% range. And we stayed there. We stayed there for a couple weeks with this data. But you all know, we reopened a lot of locations, and what happened? We bumped back up into the next bucket. right, back into that 5 to 10% range. So what that could mean is that the incidence is increasing, right? Because we know the number of tests are increasing. That variable should be, if the number of if the incidence is decreasing, that number should be continuing to move to the left, right? The rate of positive cases should be decreasing in terms of the number as it pertains to the number of tests conducted, but it's not. It went back up, and we're still up again this week as well. So when we talk about those countries that responded and how they responded to the outbreak, we're presenting this just to pose the question of, looking at how countries have done well and how countries have suffered based upon their response to the pandemic. One of the interesting things to point out is that Australia didn't have any measures for stay at home, and their numbers, again, remain relatively low. Right, and so I'm sure more research will be conducted as to trying to understand how and why that phenomena has occurred. Let's look at contact tracing. This is going to be the topic for next week's presentation, because contact tracing has been a factor in regards to how countries have fared with regards to their response to COVID-19. Those countries being in the dark blue had comprehensive tracing mandated most of the time by the governmental organizations. Limited tracing only in those turquoise locations, and no tracing at all in those locations. And you can see some overlap now, right, of countries that have fared unfortunately not well, Brazil being one of them, and very limited contact tracing, right? Now that Brazil has climbed to nearly eclipse the US in terms of cases here. So we want to continue to look at this. We'll go deeper into this next week. So in terms of prevention, let's get on the main topic here in terms of prevention of, the topic in Black Lives Matter, right? As it pertains to COVID prevention, is it relevant or is it not, right? And we're not talking about necessarily going deep into this topic on every nook and cranny of the different social economic arguments, right? What we want to do is draw some type of attention to this particular divide of prevention in different races, right? And we want to make sure that we help formulate strategies, formulate trains of thought that help prevent workers and help prevent the workforce in different industries from experiencing downtime, meaning productivity is hindered, obviously lives are affected, and we want to prevent that. So do Black Lives Matter as it pertains to health and wellness? Well, the American Medical Association believes so, right? AMA has put out a policy and says we recognize that physical or verbal violence on behalf of law, predicated by law enforcement in the public, particularly among Blacks and brown communities, represents a critical determinant of health. And they support research into public health consequences of these violent interactions, right? And so as we begin to think and reshape, the overlay between what we're seeing play out in the social justice ramification, we know that it likely has a dramatic effect on health and wellness, right? And as EHS professionals, we want to be cognizant to these trends because it will impact the way we provide prevention in the workplace. So when we look at then COVID-specific cases based on race. We've heard the disparities, but let's look at them specifically from data from the CDC. In this case, 1.8 million cases were examined. Of that, only 48% of them had race-associated data. However, this still would be a representative sample in regards to the distribution, right? And so if you look at Blacks and non-Hispanics making up 20% of cases in the US for COVID, Hispanics making up 30% of cases, as opposed to whites making up a similar amount, a little over 30%, right? And so is that relevant in regards to disproportionate incidence or prevalence? Yeah, absolutely. Let's look at the US Census data, right? Blacks make up only 13% of the US population. As Hispanics make up 18.3% of the US population. But again, we're seeing in Hispanics 30% COVID cases, we're seeing in Blacks 20%, right? So it's disproportionate, and we know it. And then if we look at then the impact to industries specifically, there are going to be industries that are at different levels of risk based upon their demographic makeup. And that's important to pay attention to, right? We want to make sure those industries have strategies for mitigating risk in those vulnerable populations. And so let's look at then the industries overall in terms of employed people in the US based upon 2019 BLS, Bureau of Labor Statistics data. 12.3% are African American as opposed to 17.6% Hispanic. Now, the one caveat here that you need to pay attention to in terms of interpretation of BLS data, these percentages of individuals in these different categories, particularly the Hispanic, Hispanics can make up any particular race, right? Whether it be Black Hispanic or white Hispanic, otherwise, right? And so the percentages here that BLS publishes don't add up to 100%. So you'll see that first and foremost. However, you'll see still yet the proportions here that may represent the vulnerable populations in these particular industries. So if we take a quick highlight of different industries that may be most vulnerable for COVID infection with these particular populations, Black and Hispanic, we can look at the motor vehicle industry, 17.2% for Blacks, right? Animal slaughtering, meat processing, right? 21% and 35% Blacks and Hispanics. The sugar industry, 18.6% and 22.2% in Hispanics. Miscellaneous paper product manufacturing, 18.4% and 13.9%. Grocery and related products from wholesalers, 14.2%, 24.6%. And then finally, air transportation, 22% and 20.1%, right? And so again, imagine these populations being affected and the ripple effects it would have in these particular industries, some of them already being hard hit by decrease in demand in the era of COVID-19, right? And so as we talk about strategies and how do we start to frame, and now we're not going to talk about comprehensive strategies for employees in the short amount of time that we have today, but we want to frame this in such a way that you begin to think about some of the classics of prevention for health and safety in the workplace and how that may play out when you start to address other factors and determinants for health and wellness and safety, okay, in particular for COVID-19. So we all know and familiar with the hierarchy of controls for safety, right? Elimination, getting rid of the hazard altogether, right? Substitution, meaning replace the hazard for something less hazardous potentially. Engineering controls, the hazard is still present, but we're able to isolate individuals from that hazard with certain controls. Administrative controls is addressing the way people move, the way people come to work, and that may limit exposure to a particular hazard. And then finally, the least effective is PPE, personal protective equipment, right? The surgical mask or the N95, the face shields and the gowns and whatnot represent a PPE approach to COVID-19, which we know, again, are less effective than social distancing and other factors. Right. And so how do we think about this? For example, again, hierarchy of controls shows up with COVID-19, engineering out the controls in such a way that causes you to place barriers in the meatpacking industry. This is a good example of that, right? Those physical barriers limiting exposure from one worker to the next. And historically, right, those workers were shoulder to shoulder, and social distancing was not possible. And so instead of changing the entire manufacturing layout, barriers were put in place. And yes, that is a means to help prevent COVID-19 transmission in the workplace, along with social distancing. Some companies are looking at wearable technology, putting a belt clip on that beeps and vibrates when you're within 6 feet of someone else in the workplace. That too is a strategy trying to limit transmission by, again, putting in place those strong social distancing methodologies, right? And so when we briefly, to go back up to the top two, elimination and substitution, right? Let's be clear, elimination of the hazard right now is an infected individual. So elimination means that you're getting that infected, you're identifying early that infected individual and you're eliminating them from the workplace, meaning you're keeping them home. We've talked oodles about that, right, before with regard to daily screening, capturing those symptomatic individuals and keeping them quarantined home safely. So that process we've been ad nauseum talking about quite a bit. Substitution, not so much, right? Substitution, you can substitute human workers for automation perhaps, but again, trying to do that in the acute phase of COVID, many companies are not heading in that direction at this point in time. And so we'll continue down. So what does this look like, engineering controls from a social standpoint? That may play out looking at the social aspects of how people get to work. Right? We know that carpooling increased risks for transmission of COVID-19. So you may put barriers in place at the workplace, but then the moment those workers step outside the workplace, they hop in a car with their cohort and they travel home. And so if we look at the disproportionality of that alone, looking at data from US data about carpooling, we know that Hispanics in particular are more likely to carpool based upon figures from 2006 and 2013, right? And then if you look at Blacks, again, higher than their white counterparts in terms of likelihood to carpool. So coming up with a solution may look like providing a means of transportation for your workforce that helps prevent them from carpooling. And even if it's a decrease from 4 people in the car to 2 people in the car, you're still decreasing the risk of transmission, right? And we're starting to think about this differently than just how do we protect workers in the workplace. A prime example, a construction company, large employer we work with, instituted some very good programs up front, right? You had to do temperature screening to get on the premises. Health screening was instituted for the workers, but at the same time, they were busing people in to get to the work site, right? And so the busing activity that was company sponsored, right, posed a higher risk of transmission potentially than what was presented in the workplace. And that's why we need to start thinking differently about the solutions that we have in place for these particular demographics. And so let's look at it from a different standpoint as well in regards to now administrative controls. Many companies have instituted administrative controls in regards to flexing work, right? Instead of having just 2 shifts, maybe 3 shifts, and now having those shifts further sliced into A, B, and C in terms of when you show up for your particular line of work so that you're not overlapped with your cohort, right? And even Salesforce.com provides a very elaborate digital platform to allow employers to do that type of administrative control in response specifically to COVID-19, right? So how does this play out though when we talk about other considerations, social, racial, ethnic? It may look like access to childcare. So just because you have a flexible schedule at work to limit exposure, right? If you don't have adequate childcare in this era of schools being closed, you may not be able to take advantage of those shifts, the variabilities in shifts, right? And so if we look at some of the determinants of health in regards to that aspect of childcare, we see that African Americans and Blacks at 38% compared to their white counterpart at 27%, and the Hispanic population at 36%. Again, access to childcare is an issue, higher so in those demographics than their counterpart, right? And so providing potentially a solution for adequate childcare during those alternative shifts may be a means to better help your workforce adjust to some of the, and take advantage of some of the means that you provide in the workplace for limiting transmission of COVID-19. Okay, and so that's how we want to start thinking about the social ramifications of Black lives, brown lives. You know, we want to make sure that we're not just continuing down a central thought of, I need to protect my workers at work, right? Because we know that a workforce is vulnerable both at work and at home, and it impacts the business. If someone gets sick at home, guess what? It still impacts the business, right? And so providing solutions for your workforce that go beyond the walls of your institution, the walls of your facility, would be advantageous to help keep them safe, first and foremost, to help keep them productive, obviously, and to help impact their community in a positive way. So with that, I know we packed a lot into this one. We're at the 30-minute mark. It's time to take questions. Thank you so much.
Thank you, Dr. Harris. That's really interesting. We have a number of questions. A lot of them are related to exposure issues, so we'll jump right in. Let's see. Is there any difference in terms of prevention between avoiding physical contact among household members as opposed to avoiding any kind of contact within 6 feet?
Repeat that one more time just to make sure I didn't miss the first part of that.
Is there any difference in terms of prevention between avoiding physical contact among household members versus avoiding any contact within 6 feet?
Got it. So if I may articulate the question just to make sure I'm understanding it again correctly, is there a difference in execution of prevention between physical touch versus proximity only within 6 feet of someone? And no, in short, if you're within 6 feet of someone, physically touching them may not necessarily increase your risk of transmission of COVID-19. And this goes back to the visualization of, we talked about orc spheres, meaning a sphere of particles, imaginary, let's imagine it, right? It exists, but this is an imaginary depiction of it. A sphere of particles kind of hovering around someone's upper body, right? From about 3 feet above their head to about abdominal height, right? And then outward 3 feet in any given direction, right? That represents the zone in which the particulates from your respiratory process, right, where the virus lives, the particles that are 5 microns or smaller are kind of hanging out in space. And so being within that zone increases your risk. That's what's been studied. That's what we know to be true. Your risk for transmission for COVID-19 goes up. Reaching out and physically touching them, if you're already within that zone, does not necessarily increase your risk. However, we know that being a caregiver in the household for somebody who has positive COVID is an increased risk factor if you're not taking precautions such as PPE, wearing the masks and gloves, etc. Right? So it's not necessarily that you touch an individual once, twice, or anything like that. It's the duration of period of time in which you're caring for somebody because you're within that or cloud zone, if you would, that increases your risk, not just merely because you're physically touching them. And so the means of protection is different for a touch because you want a physical barrier like gloves, but the primary means to prevent when you're in that 3 feet or 6 feet zone is protection of the respiratory system and the mucosal surfaces.
Okay, thank you. That's a great answer. This is an interesting one, and I have a little other question related to it. Could you speak to the potential impact of the peaceful protests in general on the spread of COVID-19? Will it ever be possible to assess the impact of large gatherings on COVID-19 spread to better evaluate the impact of reopening activities across the board? And my question related to that is there's a lot of publicity right now about the Trump rally in Tulsa, Oklahoma, and questions about will people be wearing masks, how safe will it be? So when you think about a large gathering of that nature, like potentially 19,000 seats, is there going to be an attempt to see that specific population or other populations that may be gathering for various reasons?
Got it. So I can speak to that answer, to this answer in theory, right? Because to my knowledge, no studies exist at this point that have analyzed the effects of the rallies and the protests as it pertains to increased transmission in any particular geographic. I'm sure those studies will be kicked off and will come to a conclusion in the months to come. But as it stands right now, we can speak to, in theory, would those events have an effect on increased transmission? In theory, yes, right? We know that the fundamental means of transmission in a pandemic setting is individual contacts, right? So the incremental and exponential growth of the virus is directly related to how many personal contacts does each individual have. And that was the basis for the strong social distancing and the quarantine at home, right? The shelter in place is to limit the number of contacts an individual would have. So, to the contrary, if an individual is at a rally and they have increased their number of contacts, and with the presumption that not every individual was adequately protected from a PPE standpoint, right? Then yes, in theory, it should have an effect on the increased number of transmission events. But again, to speak to an actual number and the effect thereof, that's for future studies to understand that more fully. And then in regards to these rallies, same thing, same logic, right? It's the same problem that the theme parks are facing right now. Right, to reopen safely, they know that they're going to have 25% of their capacity in the parks at any given time, which still represents thousands a day. And so they've taken precautions to still strong social distance, to have hand cleansing stations, to have masks required, etc., to help prevent those contacts. And so likewise, other scenarios such as large gatherings and rallies should still have in place protections to help minimize transmissions.
Okay, thank you. Next question is about the use of face shields. How do you see the use of face shields in addition to surgical masks as a preventive measure? Do these lend enough protection to warrant not quarantining close contacts in case of a suspected or positive case?
So we know that if someone is wearing PPE, that's adequate to limit transmission to the individual wearing PPE, that does not necessitate a quarantine event. Now, the question is a surgical mask and a face shield adequate PPE to prevent transmission to the individual wearing that equipment? And the answer is no. Right? We know that surgical masks do not protect an individual. Only an N95 properly worn does. We know that a face mask does not protect an individual from transmission. It may present a barrier to minimize, to an extent, transmission from exposure to droplets, sizable droplets, to the mucosal areas of the face. But again, it should not be taken as a protective measure to limit transmission to the individual wearing the equipment, as opposed to what an N95 does. No study has shown any equivalence. It has actually shown to the contrary in the healthcare community that has seen a disproportionate increase in transmission of COVID, even when wearing surgical masks and face shields. And to further that, if an individual who is infected is wearing a face mask or a face shield, that may be effective at decreasing transmission from them to another individual. But again, for a person that's questioning their own vulnerability, the face shield and the surgical mask don't cut it.
Okay, there's another question related to this, which I think you just partially answered, but I'm going to ask it anyway because it's specific to a certain situation. In Washington State, all employees must wear cloth face coverings when not working alone. Many employees say they cannot wear face coverings due to asthma, claustrophobia, heart disease, etc. Can we give employees the option of wearing a face shield without a mask? It may not be as effective at containing droplets, but it's an option some employees can accept. Otherwise, the employee will simply get their doctor to write a note that they cannot wear a face mask at work. Please advise.
If that is the only option, providing it, again, may provide an additional layer of protection as opposed to nothing. But again, the face shield, again, the goal of that face shield for that individual is to try to minimize droplet spread to others. And if that's all that is available, then something oftentimes is better than nothing, if I'm putting that simply, but it should not be taken as an equivalent of wearing a cloth mask at all.
Okay, and we have time for one last quick question, and I believe we've answered this before, but the question is, how long do asymptomatic people stay infected, which I would interpret also to how long are they contagious?
Well, there are actually two separate, endpoints, if you would. Studies are showing that most individuals who become infected with COVID-19 resolve their infection, meaning that they no longer have detectable virus within 14 to 21 days, right? But we also know, as we presented several presentations ago, that some individuals may stay positive on molecular testing for up to 63 days. And so the factors that increase that, again, are symptoms. So if the question is specific to asymptomatics, there's still ongoing studies, and some of the preliminary unpublished studies are suggesting that asymptomatic individuals, we touched on this a little bit before as well, may just be carriers and may not be able to transmit the virus from person to person. Much in the same way that we know that individuals can carry bacteria such as MRSA in the nares, right? And they although they carry it, they don't present as ill, right? Asymptomatic, quote unquote. And so we may have a similar scenario playing out in the COVID-19 era as well. More studies need to be conducted to understand the true nature of these asymptomatic carriers, and that's ongoing. But again, when we talk about are they carrying and can they infect, the majority of people are not infectious, even when they're asymptomatic, longer than that 14, 21 day period.
Okay, that 40 minutes sure flew by this week. I'm really happy we're able to cover the information on healthcare disparities. I think it's really useful. To answer one question from one participant, we are going to be working on a paper about causation and sharing more information from last week, so be on the lookout for that. We'll have that out within a few days. And we'll look forward to your presentation on contact tracing next week, which is another interesting public health phenomenon that we all need to learn more about. So thank you everyone for joining us again this week, and thank you, Dr. Harris, as always, for providing such valuable information.
Hey, thank you, Karen. Thanks everyone, and stay safe.
Be well.